All right, so I'm going to be talking to you on Lennox-Gastaut syndrome, really what we know and what we are learning. And I'll start with just a brief overview of what is Lennox-Gastaut. We'll talk a little bit about the history of how it sort of came to be recognized and the people that were important in that. We'll also talk about how it's different from other early onset epilepsies. I think in the past, and I think still to some degree today, we see that a lot of very challenging early life epilepsies kind of get put into the Lennox-Gastaut bucket. And we're recognizing that there are differences between some of those early onset epilepsies. And so how do we really recognize and sort of, figure out what is and what is not Lennox-Gastaut? Because that has significant ramifications for treatments. We'll talk a little bit about the causes of Lennox-Gastaut syndrome and how those actually come together to lead to seizures, as well as the important comorbidities, the learning and behavior problems. We'll ask the question, is cause important? And why might that be? And what are the potential ramifications for the future? And then we'll look how Lennox-Gastaut evolves over time, sort of what are the special challenges that families face, and that would include seizures, comorbidities, and obviously mortality. So when we look at how we think about epilepsy, this is sort of a cartoon of how we think about epilepsy. So as a physician, when I see a patient, I first of all think, what types of seizures do they have? So is it focal, generalized, or unknown? And then I kind of put all the seizures together and figure out, right, is focal epilepsy, is this a generalized epilepsy, or maybe it's an epilepsy with both focal and generalized seizures? And really Lennox-Gastaut comes then afterwards. So Lennox-Gastaut is considered one of the epilepsy syndromes. So let's talk a little bit about the history of Lennox-Gastaut syndrome. So first of all, it was the EEG features of Lennox-Gastaut syndrome that were recognized back in 1950. And this was by Dr. Lennox, who was in Boston at that time. And he recognized that the generalized spike wave, the slow spike wave that we see in Lennox-Gastaut syndrome was different than the generalized spike wave that we see in other epilepsies, particularly the childhood absence epilepsy. And he said that this is different because seizures start younger. So typically they start in the preschool years. There's a larger variety of seizure types. So other than just absence seizures, people with Lennox-Gastaut have drop seizures, myoclonic jerks. And if they have absence seizures, and most of them do, they are what we call atypical. So it's not sort of a sudden offset and onset. It's really sort of a much more gradual. And then they have other associated EEG abnormalities. He noted that many of these children had intellectual disability, and that preceded their seizures in many cases. And he also noted a much higher rate of intellectual disability in children with Lennox-Gastaut syndrome than typical absence epilepsy. So it was first recognized really that the kids with Lennox-Gastaut syndrome had a different EEG signature, but it was still not called Lennox-Gastaut syndrome at that time. The clinical picture was really then described quite nicely in France. And he noted that children who had that typical EEG picture with the diffuse slow spike wave had very characteristically these tonic seizures. And tonic seizures are the episodes where the patients become sort of generally stiff. And as well, they had other seizure types, often atypical absences. And additionally, intellectual disability, and then this diffuse slow spike wave on the EEG. And so this was reported by Dr. Gastaut a number of years later. Now, the current International League Against Epilepsy is working on defining all of the syndromes. And the current proposed definition for Lennox-Gastaut syndrome is as follows. So first of all, the clinical picture. So there must be tonic seizures. And tonic seizures are those stiffening events. They can be quite subtle, and sometimes they're only noted during sleep. And then at least one other seizure type. So atypical absence seizures, myoclonic seizures, atonic or drop seizures, generalized tonic-clonic seizures, focal seizures, or epileptic spasms. So many, as you know, many of our loved ones with Lennox-Gastaut have multiple types of seizures. Importantly, the epilepsy is drug resistant. And Essentially, all patients will have some degree of intellectual disability long-term, which can range from mild all the way to profound. The onset of Lennox-Gastaut syndrome, it begins in the childhood years, typically before 10 years of age, but occasionally in the adolescent years. But this is not something that generally begins in the adult years. And the EEG in persons with the clinical picture has really two main features. So first of all, this generalized slow spike wave, which has been recognized back by Dr. Lennox in 1950, but also importantly, another pattern, and that's called generalized paroxysmal fast activity in sleep. And we see that in essentially all ages, and it can be quite subtle unless somebody actually records sleep. Sometimes that pattern is what we see at the beginning of a tonic seizure that happens in sleep. So I'd like to talk a little bit about how Lennox-Gastaut syndrome is different than other more severe early onset epilepsies. So the distinction here can be quite challenging, but it really requires sort of one to pay attention to what types of seizures the person is presenting with, what the particular features, abnormal features on the EEG are, and then other important factors. So the child's development, what was it like before the seizure onset? How has it evolved since the seizure onset? And then other medical problems that somebody may have. So we'll talk just about a few important syndromes to distinguish from Lennox-Gastaut syndrome. And as I said, we want to distinguish those because I think increasingly we are seeing treatments that are coming out that are really targeting specific syndromes. And so it's important that we actually have the diagnosis correct in order to choose the best therapy. So Dravet syndrome is quite a different story. So it typically begins in the first year of life, occasionally up to 20 months, but usually in the first year of life. And the children have these prolonged convulsive seizures, and they're often what we call hemiconvulsive. So they affect just one side of the body, but it's rhythmic shaking of one side of the body, triggered by fever. Most cases with Dravet syndrome have a pathogenic finding on genetic analysis, and that's a change in the SCN1A gene. Another syndrome that sometimes is confused with Lennox-Gastaut syndrome is myoclonic atonic epilepsy, or what we call Deuce syndrome. And these are a few features that can help distinguish. So first of all, children with Deuce syndrome are usually developmentally normal before the seizure onset. And they have a very characteristic type of drop seizure called a myoclonic atonic seizure. And with the myoclonic atonic seizure, you have a brief little jerk, a little twitch, and then you lose tone and you fall. And oftentimes with the twitch, you can hear a little vocalization. So you might hear, oh, and then the person falls, sort of crumples to the ground. And there are EEG differences as well. The children with Deuce syndrome do not generally have that generalized paroxysmal fast activity. Another important syndrome to distinguish is epilepsy with continuous spike wave in sleep. And this is a unique syndrome where the child may have some discharges, and often does during wakefulness on the EEG, but when they fall asleep, those discharges become continuous, and it looks like their brain is seizing all night long. And with that, these children often will have developmental regression. So when the EEG becomes very abnormal and we see that continuous discharge in sleep, we see that child starting to regress, and particularly language regression. And sometimes they really can't even, they seem to be deaf. They seem to not be able to understand what is being said to them. And then once we actually treat that EEG, and it's a targeted treatment to improve that EEG, we see that development then starting to improve. And so again, important to recognize because the treatment is quite different for this. And here's just an example of a child who has this continuous spike wave in sleep. This is the awake recording. Over here, we don't really see very much, but at night you see these discharges and they're essentially continuous through sleep. The other syndrome that's important to distinguish from Lennox-Gastaut is frontal lobe epilepsy. And in frontal lobe epilepsy, you can also have tonic seizures. And so every time we hear tonic seizures, we think about Lennox-Gastaut. But in frontal lobe epilepsy, you can have tonic seizures too. But the important thing is they're asymmetric. So over here on the left side is a boy who has Lennox-Gastaut syndrome. And you can see his movements are pretty symmetric, pretty equal between the right and the left side. In frontal lobe epilepsy, the tonic seizures are often asymmetric. And so here's this girl, she's having a tonic seizure, but with her seizure, she always extends out her right arm, and her left arm always flexes up to her body. and her head always turns a little bit to one side. In frontal lobe epilepsy as well, the EEG usually shows a maximum change on one side of the brain as opposed to both frontal regions. And you can often see an MRI change on one side of the brain. And so if the seizures are not coming under control, and you do have a focus on one side of the brain, then these children are potentially candidates for epilepsy surgery. So let's talk about Carlos. So Carlos unfortunately had a brain injury at birth. It was a very difficult birth, and he had decreased blood and oxygen supplied to his brain for a brief period of time. He did have seizures in the newborn period, and those stopped with medicine. At 4 months of age, he was really noted to have not very good visual interest. He didn't seem to really look at his parents' faces, or at least follow them around. He was not even trying to roll yet. He seemed quite floppy. And then at 5 months of age, he started developing clusters of what we call infantile spasms. So these are movements where the arms and the legs kind of come into the body, and they happen periodically, sort of every few seconds for a period of several minutes, and they typically occurred several times through the day. And his EEG showed a very characteristic picture, something called hypsarrhythmia. And with the spasms and the EEG, he was then diagnosed with West syndrome, and he started on high-dose steroid. The spasms stopped initially for about a month with steroid, but unfortunately then recurred, and they persisted despite trials of other medicines. And I think, probably many of you, this is a familiar story to you. At 2 years of age, his seizures changed a little bit, and it was sort of a gradual change. And he now was developing tonic seizures, so stiffening episodes that would last just a few seconds. As well, he had myoclonic jerks. And as he started developing these new types of seizures, his spasms started decreasing in frequency. And now the EEG showed a generalized slow spike wave pattern. So the question is, what has happened to him? And he has actually evolved to Lennox-Gastaut syndrome. And this is a pattern that we see not uncommonly with some of our early onset, more severe epilepsies. Probably the most common epilepsy to do that is West syndrome or infantile spasms. But sometimes we can see this with other early onset epilepsies like Otahara syndrome. So what do we know about Lennox-Gastaut syndrome? It is characterized as a disorder where there is both a developmental and epileptic encephalopathy. And those are a lot of words. And so what does that all mean? So we know that persons with Lennox-Gastaut syndrome overall have variable degrees of intellectual disability, ranging from mild to profound. We also know that during times when they're having very frequent seizures, their development can actually plateau, or in some cases even regress, even go backwards where they actually lose skills. So what do we mean by this developmental and epileptic encephalopathy? So the term developmental encephalopathy really means that the underlying developmental and psychiatric concerns are due to the underlying cause of the epilepsy. So for example, if you sustain a diffuse brain injury at birth, that even if you don't have seizures is going to cause some developmental concerns. So we call that a developmental encephalopathy. But importantly, we think that Lennox-Gastaut syndrome is also what we call an epileptic encephalopathy. And what this term means is that the seizures themselves, the frequent seizures themselves, as well as the very frequent discharges that we see on the EEG, actually further contribute to the cognitive challenges and the psychiatric issues that these children have. And so they end up with an impairment that is over and above what you would expect from the underlying cause. And that's really important because the epileptic encephalopathy part of this is something we can actually hopefully treat with better therapies. So what do we know about the causes of Lennox-Gastaut? And we know that this is actually a syndrome that has multiple different causes. Genetic or metabolic causes, different developmental brain changes, preceding brain injury. And what's important about all of these causes is that they occur at a really critical time in brain development. We also know that there are certain causes that in some individuals can lead to Lennox-Gastaut syndrome, yet in other individuals can have a different epilepsy type. So a good example of this is tuberous sclerosis complex. Sometimes kids with tuberous sclerosis complex have Lennox-Gastaut syndrome. Sometimes they have a different type of focal epilepsy. And so really, why is that? So we think that Lennox-Gastaut syndrome really is what we call a network epilepsy. And so what is a network? We know that the brain is very, very complex. There's lots of interconnected cells. And let me just give you an example of what I mean by the term network. So say you wanted to name something that you're looking at. Okay, so what has to happen in the brain for you to actually name something that you're looking at? So first of all, information comes in from your eyes to the back part of your brain called the occipital part of your brain. And that's the part of the brain that really takes in information from the eyes to try and make sense of it. Then what happens is this information goes to what's called the visual association area. And that's the part of the brain that really says, you know, this line going this way and this color and this all means, you know, that this is a dog and not a man or not a tree or something like that. So it makes sense of what it is, the information that's coming in from the eye. And then in order to name what we actually see, it has to go to the speech center, which is sitting in the front part of the brain. And so this is what we call the network being involved, just simply to name an object that you're seeing. So we can see that there's a lot of interconnected cells. There's a lot, sort of a chain of nerve cells that needs to kind of work together for us to accomplish this task of naming what it is that we see. In Lennox-Gastaut syndrome, there's actually disruption in these networks, and importantly, disruption in two types of networks. So in the brain, there's what we call the attention networks, and the attention networks are important because it kind of nudges us and it says, hey, you know, you got to pay attention to this. This is something you got to, you know, focus on to learn. Okay, so these attention networks are activated when there's certain stimuli so that we can actually focus our attention on those tasks. The other type of network that's kind of the opposite is what's called the default mode network. So hopefully most of you listening to this talk are going to be activating your attention network and not your default mode network. But the default mode network actually is activated when you're awake but unfocused on the outside world. So you're kind of daydreaming, or you're kind of thinking about, you know, what's happened, you've got random thoughts going on. But this is an important time because this often allows us to make those connections and make sense of our world. Okay. And so typically when the attention network is activated, the default mode network is turned off, and vice versa. When the default mode network is activated, the attention networks are turned off. So back to these two characteristic features that we see in EEG. So this is what we call the slow spike wave pattern. It's often frontally predominant. And then this is what we call the generalized paroxysmal fast activity pattern over here. Okay, so these are two very characteristic findings that we see in Lennox-Gastaut syndrome. And investigators have actually studied this and looked at how does it affect these two networks in the brain, the networks that need to be activated when we have to pay attention to something, or what's called the default mode network that is active when we're sort of not super focused, but it's really allowing us to make connections to make our world make sense. And what they found was that that fast activity, that generalized paroxysmal fast activity, actually leads to these networks being activated at the same time. And so it's really hard to kind of, you know, focus on something yet kind of do some quiet reflection, right? That doesn't really make sense. The slow spike wave also simultaneously involves both of these networks in a bit of a more complex pattern. But the bottom line is that in Lennox-Gastaut kids, these networks are both activated at the same time. And so I think that really does lead to a breakdown in normal brain networks and has a significant impact on learning. And that probably is at least a good explanation of why many persons with Lennox-Gastaut will kind of plateau once their seizures really start and act up. So I wanted to talk a little bit about this term. We call it brain plasticity, and this may be something that you're aware of. But this is an important term because what it really refers to is that our brains are very kind of cool organs, and they're able to change and they're able to adapt by modifying connections and rewiring itself. And so this is why we think, you know, it's really important very, very early in life. You know, the kids really haven't made a lot of connections, and they really can learn a lot by teaching them different things. You can still do that in adults to a lesser degree, but really you can actually modify the brain by exposing it to different stimuli. So these connections are really triggered by experiences that the brain perceives. And this plasticity, the ability of the brain to kind of modify itself and rewire itself and kind of learn by the experiences that it's exposed to, is most evident in young children. And we know that in Lennox-Gastaut, this wiring is really, these connections are very disrupted. And interesting, there is evidence that in some cases, if we intervene very, very early on to avoid these abnormal connections that happen in Lennox-Gastaut syndrome, you can actually intervene and prevent this sort of co-activation of these two networks occurring. So an example of this would be a child who has very challenging infantile spasms, looks like they're starting to evolve to Lennox-Gastaut syndrome. They're found to have a lesion that one can operate on. And so it's been shown that if we do early surgery in such children, that can actually prevent those abnormal connections. So I wanted to talk a little bit about the causes of Lennox-Gastaut syndrome. And so remember, Lennox-Gastaut syndrome is an epilepsy syndrome down here, but we always, when we're thinking about epilepsies, we think of the different causes. And that's denoted here under etiology. So there's structural causes, there's genetic causes, infectious, metabolic, immune, and unknown. And we know that in Lennox-Gastaut syndrome, it's not just one category that can cause this. Children can have different types of causes, yet still evolve to Lennox-Gastaut syndrome. And we know that in Lennox-Gastaut syndrome, we can see causes in a not unusual number of cases, about 70% of cases. So just to review what those causes can be. So the most common group of causes are what we call structural causes, and they account for probably between 40 and 50% of cases. And what we see there is abnormal brain development in many cases, where there is, as the brain has developed, the cells really have migrated out and the cortex has developed unusually. And so here's an example of this, of a child over here who has what we call double cortex, where we can kind of see this line in between the white matter and the other part of the cortex. This is called double cortex syndrome. So a lot of different types of brain developmental changes can lead to Lennox-Gastaut syndrome. But another important cause is early life injury. And so this was actually Carlos, the little boy that I had showed you earlier, who had the brain injury at birth. And you can see here that he's actually had evidence of decreased blood and oxygen flow to his brain. And he also has Lennox-Gastaut syndrome. So here's a 32-month-old girl. She had infantile spasms that started at 10 months. And then she was starting, when we saw her, she was starting to evolve to tonic seizures, and her EEG actually suggested that she had Lennox-Gastaut syndrome. And of even more concern is that she had actually been doing pretty well after treatment of her infantile spasms, which went away. But then once these tonic seizures started coming, her development really started plateauing. And this is her MRI, and you can see it's very subtle, but she has a very subtle abnormality in the temporal lobe over here on the left, and that was consistent with a focal cortical dysplasia. And this was a developmental change in her brain that was leading to her Lennox-Gastaut syndrome. The rest of her brain looked very normal, and we were actually able to go and do surgery in that area, and she has been now seizure-free, and she's actually doing very well in elementary school. Another important cause of Lennox-Gastaut syndrome are genetic causes. And genetic causes can come in one of three categories. So sometimes the genetic cause can be associated with a structural brain cause. An example of that would be tuberous sclerosis complex. Sometimes the genetic cause can be associated with what we call a metabolic disorder. So a disorder in how our bodies use nutrients, proteins, sugars, fats. And so the genes can be associated with this underlying metabolic disorder. And sometimes you just have a gene change, and it's not associated with anything structural, and it's not associated with anything metabolic. And we know in Lennox-Gastaut, there's quite a few genes that have now been described in individuals who have Lennox-Gastaut syndrome. Not all, but most of them are what we call de novo variants. So these are changes in the gene that occurs in the child that is not present in either parent. And you can see here sort of the advances that we've really made in genetic testing. So at the bottom here is sort of, the year. And you can see here, even, in the last 5 or 8 years, the very, very rapid increase in the number of genes that we now appreciate can be causal for epilepsy. So here's a 39-month-old boy. He had infantile spasms at 14 months. These were actually not recognized, however, until he had his first generalized tonic-clonic seizure at 26 months. And very shortly thereafter, he started having other seizure types, tonic seizures, atonic seizures, drop seizures, absence seizures, and he also had an EEG change consistent with Lennox-Gastaut syndrome. So he had this MRI, and what this MRI shows is these subtle changes in multiple areas of the brain. And these are consistent with a disorder called tuberous sclerosis. And what was important here is this is a disorder that often can be inherited. And mom and dad were carefully looked at by our geneticist, and mom was actually found to have tuberous sclerosis. She had never had any seizures. She had a much milder picture. But this was important because what this meant, if this couple had further children, the risk of subsequent children with tuberous sclerosis and a potential for seizures would be about 50%. So again, very important for the family to know that. And here's a girl who had Lennox-Gastaut at 3 years of age. She also had cognitive impairment, and she was along the autism spectrum. She had a pretty extensive investigation, but what we found in her, and this was found on a specialized type of MRI called an MR spectroscopy, is she had this evidence of what we call low creatine, and she had a metabolic disorder that was treatable. It was creatine transporter deficiency, and we could treat her with a very high dose of creatine with improvement. So some of these causes really do translate to really much better and much more focused treatment for the patients. Now, is it not too late to do genetic testing? And the answer is no. So this, there's now been a few studies that have looked at what is the yield in adults, because many adults with Lennox-Gastaut, when they were children, we didn't have the information we have now about genetic studies. We couldn't do these fancy genetic studies. And so adults with Lennox-Gastaut syndrome, for the most part, have not been really investigated from a genetic standpoint. There's now been a few studies that have come out looking at adults with epilepsy and intellectual disability. Many of these individuals do have Lennox-Gastaut syndrome, but they found here quite a high yield. So about 1 in 4 of those adults are found to have some type of a genetic change that then explains why they have epilepsy. And you may say, well, that's okay, but you find the genetic change, then what? But I think what's important here is if these tests were positive, so if they had this genetic change, how often did this affect treatment? And you can see here anywhere from 12 to 50% of the time, it's actually making a change in treatment. And so I think it's really important if you have an adult with Lennox-Gastaut, have a discussion with their neurologist if they've not had genetic testing, because it's not too late to do this. And sometimes you really do find an answer that changes how you're going to manage the epilepsy and other issues. And so increasingly, we're finding that there are genes that have either definite or possible impacts on therapies. And here's a list of just a bunch of genes. And you can see here sort of specific treatments that we would use if patients are found to have those gene changes. We also know that over time, we are really evolving to much more precise therapies in certain genetics. Now, what we do generally for Lennox-Gastaut is we kind of, it's a bit of a Band-Aid approach. We pick a medication and the medication kind of acts in this way, and we hope that that action is going to improve the seizures, but we're really not getting to the root of the issue. So if we could identify, if somebody had a gene change and that gene change led to the epilepsy and led to the developmental problems, and we had a therapy that could go in and really address, what happens with that gene change. Maybe we can actually improve the seizures, but maybe we can also improve some of those other, what we call comorbidities. So the learning problems, the psychiatric issues, things like that. So for Dravet syndrome, which is a different type of epilepsy that begins early in life due to a genetic change, there's actually ongoing, as well as some other planned clinical trials that use genetic therapies that really target the underlying abnormality. And so the goal here is, if the more we understand about these genetic causes, I think this is going to be something that we are rapidly seeing more of in very, very specific types of genetic disorders. So moving on to how does Lennox-Gastaut evolve over time? So we know that typically with seizures, the number of seizures and the variety of seizures often, not always, but often decreases with time. Oftentimes we see a reduction in the daytime seizures, but the nighttime tonic seizures usually remain. Those usually persist. And sometimes seizures can get a little bit more prominent. So focal seizures or generalized tonic-clonic seizures sometimes get a little more prominent in teens and adults. Now, non-convulsive status epilepticus or convulsive status epilepticus is a risk at any age, but sometimes we also see over time that gets a little bit less problematic in some people, not all people. This was a study that looked at a number of adults with Lennox-Gastaut and actually followed them forward. So looking at what did the seizures look like early on, and what do the seizures look like now that they're adults. And what they found, this is looking at tonic seizures. At the beginning, all of their patients had tonic seizures, both while they were awake as well as when they were asleep. Once they actually got into adulthood, we see the number of patients with tonic seizures during wakefulness has dropped down, but we see those tonic seizures in sleep persisting. And then this is also looking at other types of seizures. So these are atonic seizures over here, and we see generally a reduction. So they don't go away in everybody, but there's often a reduction. The atypical absences are reduced. And the status epilepticus in this study anyways is reduced. This is not really my clinical experience with my older Lennox-Gastaut syndrome that goes away completely, but in this study they noted that. But you can see here the focal seizures can increase a little bit. So what happens in the EEG? So about 75% of patients as they go into adulthood and adolescence will actually show a reduction in the amount of seizure discharge on their awake EEG. Sometimes that generalized slow spike wave can actually completely go away in teens and adults. It doesn't mean you're outgrowing your Lennox-Gastaut, that's just the change that we see on the EEG. But that generalized paroxysmal fast activity usually persists, although you often do need to record sleep to see that. And so here's just looking again, that same study, looking at the slow spike wave. This is the number of patients who had that at the onset. And then this is the last follow-up. And so you see the slow spike wave goes away in quite a number of adults with Lennox-Gastaut, but this fast activity, we see it very frequently at onset, and we still see that at follow-up. So looking at evolution of intellectual disability, many patients with Lennox-Gastaut will have developmental concerns, even at the time of their initial presentation, but that's not the case in all cases. But over time, what we see is the impairment generally worsens in most patients. And so after 5 years of following your first, your seizure onset with Lennox-Gastaut, about 95% have variable degrees of intellectual disability. And by adulthood, most individuals have either moderate to severe intellectual disability. There are some with milder degrees, but most of them are moderate or greater. And the main risk factors for intellectual disability are the earlier age at onset, a prior history of West syndrome or infantile spasms, certain causes, and then frequent or more prolonged non-convulsive status also probably predicts poorly. Behavior is often a big challenge, and I'm happy to hear that there's going to be some discussion on that tomorrow, because I think for many teens with Lennox-Gastaut syndrome that I see, this is often the main factor really in poor quality of life. And behavior often worsens in adolescence. And if you think about normal adolescence, there's a lot of changes happening in the brain, right? There's physical, there's mental, there's emotional and social changes that are happening. And if you superimpose that, because remember, kids with Lennox-Gastaut also are going to have developmental changes as they go through adolescence, because their bodies are turning into adults as well. And if you superimpose that on a very severe seizure disorder, that often really can cause a lot of issues. So hyperactivity, aggression, and autistic traits. There's other mental health issues as well that can happen. So we know that in even teenagers without epilepsy, anxiety and depression are pretty common. And, so they can certainly happen in persons with epilepsy as well, and they can exacerbate behaviors. So I think, for those behaviors, you really do need to be working with a mental health professional who really has a lot of experience in adolescents and young adults with intellectual disability to help you sort that out. So other issues, sleep disruption, gait problems, and feeding problems, these are often concerns that present and persist. So we'll talk a little bit about management, and I'm not going to talk too much about that, but just the polypharmacy. So we know that as time goes on in Lennox-Gastaut, sometimes the seizures can change, or sometimes certain seizures that were happening earlier are no longer happening. So you want to make sure that you're continuing to look at that therapy and say, is that really still benefiting this person? And if not, you want to taper off what is not needed. You want to make sure that you've got your optimal therapy. So again, there's several new drugs over the last decade, and Dr. Perry is going to discuss that. And then you want to consider the timing of medication. So in individuals who have most of their seizures at night, maybe you can get by with giving just a much lower dose during the day and giving a higher dose of medication at night when the seizures are more apt to happen, and you can get rid of the sedation during the day. Again, a clear rescue plan, and that's really important to manage seizure clusters and try and avoid those hospital admissions. School and social support are really essential. So all individuals should have an IEP and additional help in the school. There needs to be a plan for what happens to the person once they get out of school, once they finish school. So getting them involved in an appropriate day program and encouraging social activities and exercise so they actually have some structure in their lives. Exercise is actually a really good thing for many persons with epilepsy, and rarely does it make seizures worse. And then access to mental health professionals, as we had talked about. And then obviously caregiver support as well. And this is really, I think, important to start having that conversation in early to mid-adolescence. So guardianship issues, social security, and then as the parents age, some discussion about transfer of guardianship to someone who knows that person well. Discussion about residence as an adult. Is this going to be in a residential facility? Is this going to be continued in their home? And making sure that they have the appropriate support and respite to make that feasible. And then connecting with other families, as we are doing right now. And I think also, making sure that caregivers give themselves permission to focus on their own well-being, because you can't be an effective caregiver if you're stressed out and you haven't slept. And so making sure that caregivers also are taking care of themselves, as well as access to mental health professionals for them if they need that. And then transition. Transition is often a very challenging time for many families. They sort of move from, the team that knows their child and knows their family very well into an adult service that works very differently than a pediatric service. So this needs to, I think it does need to happen, but it needs to happen in a very planned, stepwise process. And so this is not something that, suddenly is dropped on you. Well, next time you're going to see Dr. X in the adult floor. This really needs to be a planned program. So you need to have a multidisciplinary team, and I think nurses can be very, very important parts of this team. And here's Dr. Perry with his transition team. So to conclude, Lennox-Gastaut is a severe early onset drug-resistant epilepsy. Tonic seizures are present in essentially all individuals, and then many of them also have multiple other seizure types. The EEG shows a slow spike wave pattern that can disappear with age, and then a generalized paroxysmal fast activity pattern, which generally does not disappear with age. And it is important to exclude other early onset epilepsies. So Lennox-Gastaut should not be used just as a grab bag for all early onset difficult epilepsy, but it really is its own unique syndrome. There are multiple different causes. These all come together at a critical time in early life to disrupt brain networks, and that really results in seizures and the cognitive impairment. The cause is important. It can suggest which treatment is best, and sometimes it can lead to precision therapies, so surgery or gene therapies. And the challenges really are lifelong, and I think that you guys know this more than I do, obviously, but they extend well beyond just the seizures. So making sure that there is support for the person with Lennox-Gastaut and their family, and making sure you have a transition program. So thank you very much.